right, so again, welcome guys. Today we're going to talk about introduction to the operating room environment and aseptic technique. So again, if you guys have any questions throughout the lesson, feel free to unmute yourself and ask. So the learning objectives, we'll cover those first. So we're going to talk about the operating room environment, what to expect when you get to the OR. We want you guys to feel comfortable in the OR, and a lot of the times, you know, it can be pretty nerve-wracking when you're going to the OR. What can I do? What can't I do? What can I touch? Things like that. So we're going to go ahead and review those. We're going to discuss the standards and recommendations related to aseptic technique. We're going to define terms related to aseptic technique and the principles of asepsis, which are very big in the OR. These are our principles that we follow day in and day out for every single surgical procedure. We're going to discuss the concepts and barriers of containment and explain surgical conscience. We're going to demonstrate to you the principles of aseptic technique, explain the relationship between personal hygiene and asepsis, and we want you guys to understand what is necessary to achieve asepsis in the healthcare setting, as well as describe the needs for standard precaution in the OR. All right, so the operating room environment. This is a typical OR that you guys will see, you know, in your rotations. These operating rooms are designed to allow for traffic control flow. And we generally want to keep the general public out of the OR. So we don't want anybody just to randomly, you know, walk into these ORs. So they're designed in this controlled, with a controlled traffic flow in mind. We also want to make sure that we carefully separate between clean and dirty items. So that must be strictly maintained in the OR in order to prevent cross-contamination of objects. Now, some of the ORs that you guys will see are pretty small. So they literally only fit the necessary equipment and the team, you know, which is going to consist of your surgeon, probably 1 to 2 surgical technologists, your anesthesiologist, and your circulating nurse. At a lot of these teaching hospitals, sometimes, you know, you guys are going to be students that are going to be attending. You have my students that are attending clinical rotations. We have nursing students as well. So some of these ORs can get pretty packed. Now, the larger ORs are designed for specialty cases. Your open heart room is going to be really large to accommodate all of the equipment that's needed in there. The neuro room as well, so we use a lot of the microscope in there. So all of those rooms are those specialty rooms, usually a little bit larger, but generally this is the size of it. Of course, you're going to have your OR bed, your anesthesia equipment, and just word to the wise, you never want to walk between the anesthesia or walk through the head of the table. So if you have to get from one side of the room to the other side, I would recommend walking around the foot of the bed, just because anesthesia is already so crammed over there. You're going to have your linen hampers, your trash, and your biohazard. And of course, your OR furniture, you know, your back table, your Mayo stand, which is what we're going to use to create our sterile field. So all of those sterile items are going to be placed on there, and we're going to create that sterile field around the surgical patient. Now, a few things to know about the OR. The OR is really, really cold. You'll see a lot of the nurses, the OR personnel, sometimes they'll have their jackets on. Some of them will wear long sleeves. So if you're going to be in surgery and you're going to have to scrub into these cases, I would recommend you not wear long sleeves. You'll see when we talk about the surgical hand scrub, we do have to scrub our hands and arms all the way up to 2 inches above the elbow. So it's going to be pretty uncomfortable if you have to roll up your sleeves and keep them rolled up throughout the entire of the case. Some of these cases can be short. Some of them can take hours. So you just want to make sure if you're one of those you know, persons that get cold like me, usually you can wear just a short sleeve undershirt in the OR. ORs can be intense, they're fast paced. For the most part, you know, you have your scheduled regular cases, the routine cases that, you know, just kind of generally move along. But sometimes you can have those emergent cases, or a case can even turn emergent. So in that case, it'll turn intense, fast paced. And the staff, we all need to make sure that we do work together. So like I said, you have surgeons, residents, PA students, your anesthesiologists, we have anesthesia students as well, RN, your circulating nurse, RN students, LVN students. The surgical technologist is there, as well as a first assistant, and then we have our student surgical techs in the OR. So it's important that you have that communication within the team. If you see something is wrong or something doesn't look right, speak up. So we're all patient advocates in this field, and that should be our number one priority. So teamwork and communication is going to be important. Um, did you guys know that surgeons can be demanding? If you guys didn't know, let me tell you, surgeons can be really, really demanding. And for the most part, I tell my students that if you have all of the supplies, equipment, instrumentation that you're going to need for the case to flow smoothly, your case is going to flow a lot smoother than if you're lacking or missing instrumentation, or there's something that you need for the case that's not available. This is big. Be sure to introduce yourself. That's one thing I tell my students all the time. Anytime you walk into an OR room with a new team, you want to make sure that you introduce yourself. Good morning, I'm Yolanda Ramirez, I'm the surgical technology instructor. I'm here to observe my students. Of course, my students will say, I'm here to scrub into this case with you, right? There's also a whiteboard in every OR. That's where we keep our sharp and sponge count. So I would recommend that you write your name out there. Sometimes, well, always your nurse needs to document that you are in the case. So sometimes they don't know how to spell your name, right? And they don't want to bother you in the middle of the surgery to ask you, how do you spell your name? So write it out, or if you can meet the nurse prior to scrubbing into the case, that way you can let them know, your name and introduce yourself. The OR gowns and gloves, they're located in the room. So you always want to make sure when you introduce yourself to the surgical tech, by the time you go in there, they're most likely going to be setting up the case already. So you go introduce yourself. I'm going to be scrubbing in this case with you. Your question to ask would be, do you have an extra gown for me? Or do I need to go get it? Sometimes the packs come with extra gowns, so they'll tell you, oh, no, don't worry about it. I have a gown for you. Or no, I don't have one. Go ahead and get a gown for yourself. So the gowns are in the OR rooms. You can go ahead and open the cabinet. They'll let you know where they're at. Open up the gown. And if you know how to deliver it aseptically to the scrub tech, then by all means, go right ahead. If you're not sure, then have the another tech that's in there or the circulating nurse open the gown for you. Perhaps they can teach you how to open the gown aseptically and deliver it to the tech in a sterile fashion. Same thing goes for your gloves. They're usually located. We won't know your size of gloves. Do you guys know what size of gloves you are? Not small, medium, or large. I'm talking like 7.5, 6.5. No. So you can show them your hands, they'll gauge it, and then you want your gloves to fit nice and snug, but not too tight that your fingertips are gonna fall asleep, right? So we always recommend that you want a double glove. So you wear two pairs of gloves. We, the surgical technologists, will place your first pair of gloves when we gown and glove you. But it's up to you to go find your second pair of gloves on the sterile field and just place your second pair of gloves however you'd like. Now, any questions so far, guys? With your double gloves, the rule of thumb is you want to put half a size bigger. So I'm a 6.5 size glove. So I would wear a size 7 glove first, and then the 6.5 on top. Okay. Sometimes that doesn't work for many people. I've seen some techs that, the 7s are too big or the half a size is way too big. So in that case, you can also wear 2 6.5s. So you sometimes have to play around with it to see what fits best for you guys. Now, let's discuss OR infection control. So like I said earlier, the physical design of the OR is based on two principles. One being that physical separation between the surgical environment and any source of contamination. So a key factor is locating the surgery department in an area where traffic is limited. And like I said earlier, the general public does not have access to this. Two is containing any source of infection. So we want to carefully separate the clean and the dirty items. That must be strictly maintained in the OR in order to prevent any sort of cross-contamination of instruments, supplies, any kind of objects. For example, in the OR, we separate the decontamination room and the prep areas. So those are separate from the OR suite. They're usually in, let's say, and I'm going to use Valley Baptist as an example, only because we work so closely with Valley Baptist. So Valley Baptist has their decon and prep area upstairs. So OR is on the second floor, decon and prep are on the third floor. Most of the other facilities, they usually have them in a separate area as well. With traffic patterns, these are the physical routes that people and equipment for, in the healthcare facility take. Joint Commission recommends guidelines that follow regarding traffic patterns. So the movement of people and equipment in the pre-op area is controlled. Again, this means that only personnel can enter those specific areas. The department is separated into these three distinct areas. You have the unrestricted, the semi-restricted, and the restricted. Each area is defined by its level of asepsis. And in these areas, proper attire must be worn in all the semi-restricted areas and the restricted areas as well. So there's going to be signs that are clearly designating the department areas, and those signs, they're clearly visible. It's important that you adhere to these traffic patterns, um, just to make sure that you're wearing the proper attire when you're in those areas. And these traffic patterns are monitored. Most facilities require a badge to gain access to a semi-restricted and restricted areas. So for my students, we usually don't get badges, not even the instructors. So we usually have to wait for somebody to let us in. My students usually arrive to the OR about 6:15, 6:30 to be ready for a 7:30 case, because they have to change into their scrubs. They have to go get their scrubs, change into their scrubs, do their surgical hand scrub, and then go get their case assignments for the day. So there's sometimes that they tell me, I've been out here waiting 15 minutes and nobody has passed by. So sometimes the staff doesn't get there till about 6:45. So it really just depends. You can also talk to your preceptor. I have my students message their preceptors and say, you know what, I'm going to arrive at 6:30. Can you let me in? So in that case, they'll usually let them in. OR zones and areas. So the unrestricted areas outside of the surgical suite, they're outside of the surgical suite. So surgical attire is not required in this area. Examples of these areas are like, for example, the reception area, family waiting rooms, the changing room or the locker room, the lounge. So you don't need to wear any sterile attire or scrubs in these areas. The semi-restricted area requires you guys to wear surgical attire. So this includes a scrub suit, the surgical scrub hat. These areas include the OR hallways, any offices located within the OR, the sterile instrument and supply storage rooms, the sterile processing areas. So when you guys walk into these semi-restricted and restricted areas, you're going to notice some red tape on the floor. And there'll be a sign on the door that says all personnel must have OR attire beyond this point. So this is an indication to you that this is a semi-restricted area. So make sure that you have your proper PPE, for example, your bouffant, your shoe covers on. And the restricted area consists of the actual OR, where we're going to perform these surgical procedures. It also includes sterile storage rooms, like substerile areas, like we call them the center core. So those are usually located within the inside of each OR. And for these areas, personnel are required to wear a complete scrub attire, including a surgical cap. If you're ever walking into the OR, you also need to make sure that you have a surgical mask on as well. Okay. Now, the scrub sinks. So you'll notice in most ORs, the scrub sinks are going to be located right outside each OR room. And this is so that you can easily scrub your hands and proceed directly to the OR after your surgical hand scrub. So what we don't want is for you to scrub, 20, 30 feet away and then have to walk down the entire hallway to get to your OR, right? You run a higher chance of contaminating your hands or coming into contact with somebody touching your hands. So they're located right outside the ORs. Each scrub sink you'll find has an antiseptic hand rub. It has face masks. It has a face shield. It has your surgical mask as well. protective eyewear. So you guys can provide your own protective eyewear if you'd like. I have some students that prefer to take their own plastic goggles. The only thing is you do want to make sure that the shields do cover the sides of your eyes. Okay, so you want to make sure that you have protection all around. Uh, basic reading glasses are not going to be useful for your PPE. So you're also going to find that the scrub sinks, there's scrub brushes, the surgical soap. The scrub sinks are hands-free operated. So some of them have sensors that will turn on and off the water, just like you find nowadays. So you just wave your hand over the sensor, it'll turn the water on. And then once you move out of the way, you can turn the water off. So some of them have a set timer. So it's got a little button, you push the button, it gives you automatically, it'll give you an option for 5 minutes or 10 minutes. So you kind of pick, and then it'll automatically shut off. In our lab, we have knee operated sinks. So you just hit the little lever with your knee, turns on the water, same thing, hit it again, it'll turn off the water. And some hospitals, I've even seen some of the older hospitals have sinks that they actually have a handle at the knee level. So you have to insert, it's like a little hook. You have to insert your knee into the little hook and then open your knee out and to open it and close it. So you're going to find a lot of different variations of scrub sinks, but they are all going to be hands-free scrub sinks. Okay, moving on. Aseptic technique. So this is a set of practices that are used to create and maintain the sterile field and prevent surgical site infection. So pretty much it's the foundation of infection control in the OR. Now, developing good aseptic technique is going to take time and practice on your end. Everyone is going to make mistakes. This is why I love to teach this to you guys in the lab, because you can make the mistakes there, we can practice them, we can fix them, and you don't necessarily make these mistakes in the OR. But if you do, don't worry, there's always a way to fix it. When you first begin to learn aseptic technique, it's got so many rules and little tidbits here and there and so many little skills. So you're going to feel a little awkward and sometimes uncomfortable. But as long as you repeat the practice, you're going to start to develop some confidence there. Now, like I said, you're going to make mistakes. You're going to have minor breaks in aseptic technique. And those breaks in technique can be corrected as long as they're reported. So you do have to speak up. If, for example, we put on your gown and your gloves and you turn around and accidentally touch the video monitor for a laparoscopic case, you need to speak up and say, you know, whoever is in that case with you, I touched the monitor with my right hand. Okay, simple fix. The circulating nurse can take off your top glove or take off your glove if you haven't double gloved yet. And then the surgical technologist just puts on another glove. If you contaminate your whole gown or somebody touches you by accident, then we have to remove your whole gown. We would probably send you to go scrub again and re-gown and glove you. So it really just depends, just as long as you want to make sure that you speak up and you report it. Nobody's going to get mad at you. The difference between medical asepsis and surgical asepsis. So when we're doing medical asepsis, this reduces the number of pathogens. We call this clean techniques. And we do use medical asepsis when we're administering medications, enemas, tube feedings, daily hygiene. So this is just your basic hand washing techniques that we use, right? Now, when we talk about surgical asepsis, this eliminates all pathogens. So we refer to this as sterile technique. We use surgical asepsis in dressing changes, any type of catheterizations, and surgical procedures. Now, with that being said, keep in mind that although we refer to this as sterile technique, we can never sterilize the skin. Okay, we can only render it surgically clean. So if you hear somebody say, well, go sterilize your skin, we can't sterilize it. It's surgically clean. Sterility, when you sterilize an object, it's completely free from all living microorganisms, including microbial spores. So the term sterility, or the sterile term, it's absolute. Items are either sterile or they are not sterile. There's no, it's sort of sterile, it's yes or no. Now, a sterile object is known to be sterile only after it's been processed with a proven method of sterilization. After sterilization, this specific object must be maintained in an environment known to prevent contamination. So for example, once we sterilize our instrumentation, they are kept with sterile instrumentation. So you don't mix and put them side by side with something that's not sterile. In the OR, you're going to find that we have a sterile supply room with all sterile supplies and an instrument room with all the sterile instruments. You never want to store sterile items next to unsterile items. And for this reason, you'll also notice that the supply carts that are, you can wheel back and forth from one room to another, those are kept covered, just to maintain their sterility as well. So with the concepts of barriers, the principles of aseptic technique are based on the concepts and practices of placing a barrier between a source of contamination and a sterile surface. So you have three types of barriers. We have a physical barrier, which prevents a non-sterile surface from touching a sterile surface, a chemical barrier, which is produced by the residual effects of an antiseptic, and distance. As the distance between a sterile surface and a non-sterile surface increases, the risk of contamination decreases. And I'll give you some examples here. So here's an example of the physical barrier. So our drapes are physical barriers, right, between the patient's skin, the operative area. Your sterile gloves, they prevent direct contact with the non-sterile hand. Your bouffants that we cover with our hair, those are examples of physical barriers as well. So it contains dander within the hair in the sterile cap. And like I said, the sterile drapes, they provide that physical barrier between the patient and the surgical team. Now, a chemical barrier, an example of a chemical barrier is produced by the residual effects for the antiseptic used during the surgical skin prep or the surgical hand rub. We do use this chemical barrier in anytime we prep the patient's skin as well. And not pictured here, distance. So as you learn aseptic techniques, you'll need to visualize sort of like an imaginary space around the sterile field. So our rule of thumb is 12 inches. 12 inches must be allowed between sterile and non-sterile surfaces. When you guys go into the OR, like I said, you're going to walk in and most of the time the techs are going to be setting up the case. You're going to notice that they pull the tables and all of their sterile furniture. It's at least a foot away from the wall. So we don't set up directly right next to the wall. So it has to be at least a foot away from the wall. Anytime you're walking around a sterile field, if they've already been draped and the sterile field's been created and the furniture's been moved around the patient, you want to keep that 1 foot or 12-inch distance from the sterile field. So you walk around it, maintaining that distance, and you always want to face the sterile field as well. You never want to give your back to the sterile field. You don't know what's going on. You can't see back there. You can see what's right in front of you. So always just make sure that you're monitoring the sterile field. Easy way of thinking, every time I see a new student, sometimes we get high school students as well doing tours and observations in the OR. I always just tell them, if you're not sterile, if you're not blue, don't touch anything that's blue. Okay, and just stay a foot away from it. At least a foot. So if you can stay a little bit further away, even better. Now, a surgical conscience. Aseptic technique is based on surgical awareness and surgical conscience. So each of you guys is going to be responsible for protecting the sterile field. Now, of course, it's the surgical technologist duty to protect the sterile field, to maintain it, and to be vigilant, make sure nobody contaminates. So on top of making sure we have the instrumentation, supplies, everything that the surgeon needs, we also have to be able to watch the sterile field and, just to make sure that nobody else contaminates. And in an event that results in contamination of any part of the surgical field is called a break-in technique. So every person of this team must be conscious of every contamination and report them immediately so that appropriate action can be taken to correct the error. Like I said earlier, most of these breaks in techniques can be corrected. So it's not a big deal. We just have to change whatever it is. If you contaminate an instrument, we can just pass that instrument off. Admitting and reporting any breaks in technique, that demonstrates a high level of professional maturity and surgical conscience. So a good surgical conscience consists of honesty, making sure that you're honest. If you contaminated, like I said, nobody's gonna scold you or get after you, which is what students are always afraid of. I don't want anybody to get mad at me. I don't want the surgeon to yell at me. They're not going to yell at you for contaminating, and they do realize that we're all students here. You have to be willing to accept responsibility for your actions. So you have to speak up and say, I made a mistake. Now, I can't say that the surgeon will never yell at you. Perhaps they may. I myself have been yelled at. I don't want to say plenty of times, but a good number of times in my career. It's not the worst thing in the world, guys. And I can tell you that you will definitely learn from it, and you probably won't repeat that same mistake again, right? So just kind of an FYI. You also want to be committed to maintaining competence and committed to practicing the principles of surgical asepsis. As you start to work in the OR, you're going to start to pick up, what these techniques are. And, the more you practice it, the better you're going to be at it. All right, so the following few slides are pretty much our principles of aseptic technique. This is just our general rules and guidelines of working in the OR. So my students, all the OR personnel, they all follow this, this is their guidelines. This is how we work. So sterile surfaces contact only sterile surfaces. Now, contamination of a sterile surface occurs when a non-sterile surface touches a sterile surface. For example, if the circulator's bare hand touches your gloved hand when they're giving you an item, then we just contaminated that, right? It's no longer a sterile surface. Next, a sterile item is considered sterile only after it has been processed. Now, before any item is delivered to the sterile field, the wrapper where it's wrapped in, you have to make sure that you inspect that wrapper. What we're looking for is if there's any tears or holes, any signs of water damage. Just because this item has gone through the sterilization process doesn't mean that it's still sterile. So there's so many variables that we need to consider that could put this item or could make it non-sterile. So you just inspect it before you open it. Sterile drapes, gowns, gloves, and table covers are barriers. So we talked about this already. These are the barriers between the non-sterile areas. They're creating a sterile field. The edge of any sterile drape, wrapper, or covering is considered non-sterile. Now, when a sterile item is open, you'll notice, like let's say when you're peel packing an item, a package, the little peel pack where it's sealed, that edge of the wrapper is not considered sterile. So the item must not touch the item. So there, we use a special technique, which we call flipping items onto the sterile field. So we don't slide them off the wrapper, we actually flip them onto, let's say, a basin or the back table so that they don't touch those edges of the wrapper because they're not considered sterile. Regarding sterile liquids and bottles, the bottles with an edge or a lip may be delivered directly from the bottle. So the bottle is actually not sterile, but the contents inside, let's say, for example, saline, your sodium chloride is sterile. So that needs to be poured onto the back table for the surgical technologist to use for irrigation. So they can pour it onto the basin, onto the sterile field, but the liquid must be completely poured into the basin. So there shouldn't be any leftovers. You cannot pour half of the liquid because you have a small basin and then recap the bottle and pour the rest later. So once that bottle is recapped or once it's brought back up, it's no longer considered sterile. So if I had a small basin and I was only able to fill or to use half of the irrigation, then the other half is just a waste. It's no good anymore. Questions so far? If there's any doubt about the sterility of an item, you want to consider it contaminated. We use the phrase, when in doubt, throw it out. Even if perhaps it may not be contaminated, but you're not quite sure, if your arm accidentally nudged or touched the IV pole, consider it contaminated, regown and reglove. Okay. And on that note, if someone tells you you're contaminated in the OR, That point in time is not the time to say, no, I'm not contaminated, or why. That's not a time or a place to question it. You just say, okay, what did I contaminate? Step away from the sterile field and then correct the contamination. The draped patient is the center of the sterile field during surgery. Equipment that's not draped must remain outside the sterile field. So remember those 12 inches, that 1 foot, that's allowed between sterile and non-sterile surfaces. So we need to make sure that we maintain that distance. The surgical techs will bring in their back table, their Mayo stand, any other draped furniture to surround the patient so that we can make that patient the center of the sterile field. Sterile gowns are considered sterile only in front from mid-chest to table level. So this is going to be important for you guys. You're going to be gown and gloved, right? So once we gown and glove you, you should not drop your hands below table level or below waist level. So we are all different heights, right? I'm short. I know you can't tell here, right? I'm 5'1", so I'm short. And if I have a team member who's, 6 feet tall, they're just gigantic to me, but their sterile boundaries are going to be different. So rule of thumb is nipple line or mid-chest level to table level. That is your sterile area and only in front of your gown. Your underarms, the axilla, those are not considered sterile. So you never want to be caught crossing your arms while you're waiting for the surgeon to get there, like looking like you're bored. And you never want to drop your hands below table level. And I always tell my students, if you're not near the table and you're waiting, off to the side, then just cross your hands like this and put them over your belly button. You can't go wrong there. So you don't want to be standing like this, gown and gloved in the OR. Can y'all see me? Because you're going to look like you're just very, very new, and everybody's going to know, oh wow, we really have to pay attention to this person right now. So we don't want to stand around like this. We don't want to wait like this. Cross your hands and put them over your belly button. So now we know what to do with our hands. Sterile tables. So sterile tables are considered sterile only at table height. So only the tops of the table is considered sterile. The little edge on the table is not considered sterile, so we should never touch the edges. Same thing goes for the patient. When we drape the patient, only the top of the patient is considered sterile. The sides, even though they're completely draped with a sterile drape, they're not considered sterile. So if you ever see any suture ends or like the lap sponges, the blue X-ray detectable string that comes with the lap sponges, if they fall over the edge, they're considered sterile. They have to be removed from the sterile field. I'm sorry, they're considered contaminated and they have to be removed from the sterile field. So only the tops of the table are considered sterile. Sterile personnel must remain within the sterile field. So if you're a scrub team member, you should stay within the sterile field. There is no reason why you should step away from the sterile field to be doing anything else. So the main thing, you're going to be right in front of there next to the patient. Everybody's going to be scrubbed, draped, gown, and gloved. And the last set of our principles, non-sterile team members must never lean or reach over a sterile surface. So if you have a draped patient and you have to pass something to a non-sterile team member, obviously you're not going to pass it over that draped patient, right? So you never want to lean or pass anything over something that's draped, something that's sterile. Movement is kept to a minimum during surgery. Usually once we get started, you're pretty much already set in place. The surgical tech or the surgeon will tell you where to stand. So usually they'll tell you stand across from me so that you can see. Like I said, there's going to be multiple students and personnel scrubbed into some of these cases. And in some cases, a surgeon may ask you to switch with another student. So you go down towards the feet and allow this other student to come up so that they can see what I'm talking about. So in those cases, sterile team members, they must pass other sterile team members either back to back with both of your backs passing each other or front to front, okay? And I know it's a little hard to understand right now, but if you get to the OR, ask someone how to pass back to back, front to front, and they'll show you I can't really demonstrate it for you right now because I don't have anybody to do it with, but you never want to give your back to the sterile field, in other words. Drapes and linens should be handled as little as possible. So this prevents the release of lint and any dust particles to be floating around. We want to, keep that to a minimum. And when draping a surface, or let's say if you're drying your hands with a towel, I know for myself, now I don't do it, but you always kind of want to shake the towel, right? Shake the towel open. So that's something we should not do. You never shake a drape or a towel. If anything, you just gently unfold it to minimize the release of that lint or any dust particles onto the, onto the air. Talking. Talking is kept to a minimum. And the reason for that is that the mouth, there's plenty of bacteria in the mouth. Surgical masks, you want to make sure that they do contain the bacteria if you're wearing a surgical mask, if you're wearing it properly. So it does have to sit snugly. So make sure that your nose bridge is it's snugly fit on the nose and it's covering the chin. So it's nice and snug, not too tight where you can't breathe, right? But not loose enough that you can kind of see your whole mouth from the side of the mask. So if the mask is not worn properly, it does provide little protection against any aerosol droplets, and you're literally right in front of that patient in an open wound. So talking is kept to a minimum for that reason. Moisture carries bacteria from a non-sterile surface to a sterile surface. So when water comes in contact with a sterile drape, let's say, for example, my circulator is pouring my irrigation fluid into my basin or my pitcher, and he or she accidentally pours, it pours out of the basin and it splashes onto my drape. So we call that strike-through contamination. So this occurs when moisture infiltrates the drape from the sterile side and it moves to the non-sterile side. So then that section of the drape is going to be considered contaminated. So we have to fix it, cover it up, or make sure that it doesn't seep through. You can also have strike-through contamination when you guys are performing your surgical hand scrub. So I can guarantee that there's going to be a handful of you guys that are going to perform your surgical hand scrub, and when you're done, you're going to be soaked on the front of your scrub top. I guarantee it. Always happens. So we want to avoid any splashing onto the scrubs when you're performing your surgical hand scrub, only because it could cause strike-through contamination when we put your gown on. So you want to make sure that the scrub suit fits nice and snug, and try not to splash any on your scrub top. And lastly, the sterile field is created as close as possible to the time of surgery. And reason for this is that once the supplies have been opened, they have to be continuously monitored. So if there's a delay in the case, if I open up an hour ahead of time and it takes me 15 minutes to set up, well, I have to sit there and stay scrubbed in and watch my case by myself. So we usually keep that open or recreate it as close as possible to the time of surgery. And this is just an example of the sterile field. So again, this patient is the center of the sterile field. So this is all sterile. The gown is only sterile from mid-chest to table level. And like I said, this is going to vary depending on height. The tabletop is considered sterile. The hands, which are above table level, are considered sterile. But the sides, the back, this circulating nurse is not gown and gloves, so they're not considered sterile. The assistant, the hands and the front of the gown are considered sterile, but not the back. Of course, anesthesia is not considered sterile, and the sides of the drapes are not considered sterile. The OR lights that you'll see up here, we have sterile OR light covers that we use to place on these handles that you can see sticking out right here. So you have to be really careful when you're placing those light handle covers, and make sure that your hand or fingers don't accidentally touch the outside as well. So that's where I tend to see a lot of students tend to contaminate, because they don't pay attention and they try to put it up real quick. So they're super nervous, whatever the reason, and they contaminate their gloves on here. Okay, here's what you're going to look like in the OR. So surgical attire is going to be worn in all areas of the OR. This includes your scrub suit, top and bottom. They're not very fashionable, so they're not figs, that's for sure, right? So they're going to fit nice and loose like this. You don't want them to be super tight. You want to make sure that you're comfortable. You also don't want them to be super loose. So make sure you find your correct size. It includes the head covering, which is your bouffant right up here, your surgical mask. There's different kinds of masks. This blue mask is just a surgical mask. This orange one you see here comes with a face shield already included with the mask. You're going to have your shoe covers. Your basic shoe covers are these right here. And if you're doing any cases where you anticipate a lot of blood loss or fluid loss, then I would recommend you wear these long, big, larger shoe covers. Examples of these cases would be C-section. So even though the drape is supposed to contain the amniotic fluid when we perform the C-section, sometimes that drape doesn't catch it. So all that fluid, you don't want it on your shoes. So, or your scrub top, your scrub legs. So I would recommend wearing those. Orthopedic cases, we also wear those. Those tend to be a little bit, there's a lot of irrigation loss during the arthroscopies, and the floor is really wet, so you don't want it to soak through. Um, like I said, the attire has to be worn in restricted and semi-restricted areas. So the ORs, they provide, or the facilities do provide freshly laundered scrub suits that can be put on each day. Some facilities, you'll have to meet someone and ask them for a scrub suit. Other facilities will give you a code to, like, for example, Valley Baptist has a ScrubX. So they'll assign you a username and code so you can go select your scrubs from there. It's kind of like a vending machine for scrubs. And you only want to change these when they're contaminated with blood or bodily fluids. You can wear an undershirt here. If you wish, you can wear an undershirt, but it must be contained within the scrub suit or the scrub top. Your head covering should be donned first in order to prevent shedding of hair, dandruff, or any bacteria onto the scrub top. And it's usually a bouffant style. It should cover the ears entirely. So you see here, it covers the earlobe. Shouldn't be worn behind the earlobe. It should be worn as you see it here. There's also long sleeve jackets that can be worn by non-sterile team members. They call them like warm-up jackets. They do prevent shedding of skin cells, so they must be laundered by the facility, or sometimes the facility provides disposable ones. So if you're not scrubbed in, it should be buttoned and snap closed at all times. Lab coats must be worn completely buttoned when entering or leaving the OR department. So if you're leaving to lunch, you should wear your lab coat completely buttoned, or if you're going to another department. Jewelry. Jewelry of any kind is a potential source of pathogens. I usually tell my students, leave all your jewelry at home. Even your earrings, shouldn't be wearing any earrings, necklaces, rings, watches. So surgical personnel must remove all rings, bracelets, wristwatches before entering the restricted area of the surgical department. If you choose to bring in your jewelry, you do have to remove them, anything that's on your hands, for the surgical hand scrub. So you can't perform your scrub with the ring on, although I have seen some students do that, and they get all the way up to the point where we're gonna dry gown and glove them, and then you have to tell them, you have to take that off, go scrub again. I've seen some students lose their jewelry. Some students will say, I have to wear my wedding ring. I cannot take it off. Okay, but for surgery, you do have to take it off. So sometimes I'll recommend that they put, or I used to recommend that they bring a safety pin and pin it to their scrub top. But it's at your own risk, guys. Some students will throw in their scrubs into the laundry hamper, and then they go home and then they realize my ring was pinned to my scrub top, and now, got to go back and look for it, and hopefully you find it. So bring your jewelry at your own risk. In the OR, you don't want to be the cause of, you don't want your earring to fall into the surgical wound, right? And then you'd be put on the spot. So again, for that reason, I just tell students we don't allow any jewelry in the OR. Same thing goes for lashes, guys. I just had a phone call yesterday about fake lashes. So I know they're all the rage right now, and the bigger the better. But the OR, like I said earlier, it's not a fashion show in the OR. We're in there to help these patients to get better. So I would avoid any lashes as well, fake lashes. Just FYI. Hand hygiene. So the purpose of the hand hygiene, this is the most important tool for preventing the transmission of microorganisms in the healthcare setting. There's a couple of types. So there's hand washing, which hand washing is event related. Usually we perform a hand wash before and after patients or specific task or event. And hand antisepsis, this is the application of an approved hand antiseptic, which is also available to you at the scrub sinks. So if they're not visibly dirty, you can use hand antisepsis. Now, the skin, you guys know, carries both resident and transient bacteria. Resident or your normal flora, these are the bacteria that reside in your skin, right? This is why we cannot sterilize our skin because we have that resident bacteria. And then your transient bacteria, this is the bacteria commonly found in the hands that you acquire by direct skin-to-skin contact or via indirect objects like a pen. Now, the purpose of rigorous hand hygiene in healthcare is going to be to reduce the number of bacteria to an absolute minimum. So the goal, of course, is going to be to prevent infection in the OR. We don't want to, cause any infection to our patients. Fingernails, again, this goes with the lashes. So fingernails must be short. They must be no longer than 1/4 inch. So I tell my students, if you can see your fingernails when you're looking at the palm of your hand, I can see mine are a little long, then they're too long. You shouldn't be able to see your fingernails. Nail polish must not be worn. This is sort of a debate in the OR right now, and artificial nails must not be worn. Only because you have the introduction of, what is it, shellac and dip. So I'm not going to say too much on that, but you will see some people in the OR with freshly manicured hands and nails. If you ask me, we're in a healthcare setting, you're a healthcare provider, and the OR, there really is no business for nail polish of any type in the OR. But there are some guidelines that have been published by AORN and the Surgical Technology Association of Surgical Technologists. So it does say that nail polish can be worn if it's freshly applied and free of chips. But again, that's a big debate right now. Every facility is different as to what they're allowing. So if you must, you can inquire with the specific facility you're scheduled at and see what they say about that. Before performing any hand hygiene procedure, make sure that you inspect your hands for any visible soil. Again, you want to remove all your jewelry and kind of go ahead and clean your nails. Also, going back to those artificial nails, so artificial nails are not allowed. So they do harbor bacteria. So there have been studies that show, different kinds of organisms underneath the nail beds. So you just want to be careful with that. So hand hygiene summary. Surgical hand antisepsis, this is a technique that reduces the number of microbes on the hands and the arms, and we're trying to reduce it to an irreducible minimum. Now, with routine hand washing, this should be frequently performed during the workday, specifically between patient contact. So in between cases, you want to go out there and just do a regular routine hand wash. Now, two methods of surgical hand antisepsis are acceptable. We have a traditional surgical hand scrub, which uses a scrub brush, liquid antiseptic soap, and water. This should always be your first scrub of the day. So as soon as you walk in, you of course change into your scrub attire, put on your bouffant, put on your shoe covers, put on your mask, your goggles, and then go perform a surgical scrub, and then go, locate your surgeon or locate your assignment. And then it should also be done after lunch. So first start of the day, and then when you come back from lunch. The other surgical approved scrub is going to be the surgical hand rub, which uses surgical grade antiseptic liquid. So in between cases, after you've done your first surgical hand scrub of the day, every case after that, you can use a surgical hand rub. So it is acceptable to use throughout the day, except when your hands are grossly soiled. So if they're grossly soiled, then you would perform a surgical hand scrub. Now, when to perform a surgical hand scrub? So immediately before donning sterile gown and gloves. So you want to don your PPE, put on your face mask, put on your eye protection. If your case has x-ray, then you want to make sure that you put on a lead apron and your thyroid shield as well. So you don't want to forget that. Before that, you want to make sure you open your gown and gloves to the surgical technologist. Let them know, here are my gown and my gloves. And then you can go out and perform your surgical hand scrub in the nearest scrub sink. And then after direct exposure or skin contact with blood or bodily fluids, that's another reason when you would perform the surgical scrub. So there's two types of acceptable methods for the surgical scrub. One is going to be the timed scrub. The other is the stroke counted method. So the stroke counted method has 10 strokes for this finger, 5 strokes for this one, 5, 10 here and there. It's a little confusing. So we teach the time surgical hand scrub in our program. This consists of a 3 to 5 minute scrub. Each facility can have a different policy regarding the time on the scrub, so make sure that you check with them beforehand. For example, most facilities require you to perform a 10-minute surgical hand scrub for all total joint procedures. So in those cases, you would perform the 10-minute. Typically, one round of scrubbing your right hand and then your left hand, that takes about 3 to 5 minutes. So if you're going to perform the 10-minute surgical scrub, you just rinse your hands after that first round and then start all over again and complete a second round. That's all that is. I also used to work with a neurosurgeon who wanted us to perform a 10-minute scrub for all his cases. So we did. It really just depends. It's always best for you to ask your team regarding the hospital policy or the surgeon's preference, so that way you're performing the correct surgical scrub. Now, the surgical hand rub can be used in place of the surgical scrub unless the facility states otherwise. So performing the surgical scrub without a brush or sponge is acceptable. The practice of using a brush, this can actually damage the skin, resulting in increased shedding of microorganisms from the hand and arms. So scrubbing with the brush also contributes to an increase in the shedding of skin cells. You want to do a gentle scrub, guys. You want to avoid harsh friction with the brush because it does cause skin irritation, especially you're going to be scrubbing, all day long. So your hands are going to be irritated. They can be a little bit sensitive. Several studies confirm that the use of a brush or sponge is not necessary, as well as demonstrating lower bacterial counts when a brushless surgical scrub is performed, as compared to the use of a brush, in particular when an alcohol-based solution is used that consists of 1% chlorhexidine gluconate and 61 to 70% alcohol. So these next few slides pretty much just go through the surgical scrub sequencing. So prepare for the surgical scrub by ensuring that your scrub suit top is tucked in to your scrub pants, or it's sufficiently scrubbed so that it remains dry. You want to make sure that you roll up your sleeves if necessary. Some of these scrub tops are a little bit large, so roll up the sleeves so that you're able to perform your scrub 2 inches above the elbow. Ensure that everything fits snugly, nothing is uncomfortable, your face mask fits well, it's not, coming up into your eyelashes, your glasses are not fogging up. And if you need to use the restroom, now is the time before you scrub into the case, okay? You don't want to ask to go to the bathroom after you scrub into the case. Remember to adjust your mask and PPE before starting the scrub. You perform a routine washing of your hands and arms, just like we described earlier, and rinse your hands and arms thoroughly, and then we can start the actual portion of the scrub. So to start this surgical hand scrub, you want to grab a sterile scrub brush. They're usually located in some little boxes right on top of the scrub sinks. Grab a packet, remove the nail cleaner. You want to wet both hands and arms and lather the entire hands and arms. So you're going to grab some soap from the soap dispenser, which is also hands-free. Grab some soap, lather entire hands and arms all the way up to 2 inches above the elbow. And holding the brush in one hand while carefully cleaning the subungual areas on each finger under running water. So whatever we scrape off from under the subungual areas, you want it to drain out with the water. Focus is placed on the fingernails because of the many different types of bacteria that we can find under the fingernails. And then once you clean under the fingernails, you can discard the nail cleaner. So remember I talked earlier about keeping your hands at waist level? It starts from this point. So when you're discarding that nail pick, you really just reach out, keep your hands above waist level, and just drop the nail pick, which is a little something that we have to get used to because you always just kind of want to toss it and bring your hand close to the trash can. So that's no longer done. You just reach out and let it fall into the trash can. Next, you moisten the sponge with the antiseptic soap, create a little lather, and begin with the nails. And Ms. Gonzales will go over the video with you guys. This is, you can kind of use this as notes as to the sequencing. So you're going to keep the surface of the fingers, hands, and arms in mind as you begin to scrub. So we want to envision as the fingertips being clean, and we're working our way from clean to dirty, and the elbow being dirty. So scrub each side of the finger and the hand separately. So you want to envision that each finger has 4 sides, right? So the side, the back where the nail is, and then the inside where the palm is, and then the inside next to the wedge. Then from there, you can move on to the wedge and then kind of follow the same thing. Fingers have all 4 sides. Scrub each one individually. And then once you scrub all fingers, the last one would be the pinky. You move to the palm of the hand. And from there, we start in a circular motion. And then from there, we proceed to the arm. I know it says 10 strokes here. This is if you're doing the 10-stroke method. But once we get to the arm, to the wrist, you'll move in a circular motion, and you're essentially just moving back and forth, you'll see in the video, without returning to the previously scrubbed area. So you don't want to, once you scrub an area, you're just going to slowly transition to the next until you get to up to 2 inches above the elbow. So during all this time, you don't want to allow the scrubbed hand or arm to contact any part of the sink. So a lot of the times what I see is my students are so concerned with getting down here and their hand kind of slips and then they touch the faucet with their fingertips. So if at any point that happens, you would have to rinse your hands and start the scrub all over again. Okay, and if that happens, by the time you actually go scrub in, I've seen this happen, by the time you actually go scrub in and get gown and glove, the surgeon is walking out of the room because he's done with the case. So you just missed the whole case. We don't want that to happen. Avoid splashing water on the scrub suit, right? We talked about that. Donning a sterile gown over a wet scrub suit is not acceptable because you run the risk of that strike-through contamination that we talked about. And always keep the hands higher than the elbows at all times. Even when you're rinsing, you want that water to drip off of your elbow, not off of your fingertips. So when you're rinsing, you're kind of going like in a scoop-like method, fingertips and then scooping up and coming out towards you. When the scrub is complete, you rinse the hands and the arms by passing first the hand, then the arm under running water. You want to do this a little slow and just slow and steady, right? You don't want to whiz through the underneath the faucet because then you're going to have to rinse your hand like 5 or 6 times. If you kind of do it slow and controlled, you can kind of just rinse it, move it underneath the faucet a couple of times. You also don't want to move the arm back and forth through the water. It's only one motion and one way, so it's going forward towards the fingertips and coming out. You want to try to remove all the residual soap because it can harbor debris, and if you have a little bit of soap left over, it is going to make it harder for you to put on your gloves. And then from there, you proceed to the OR. You want to open the OR door by pushing it open with your back. All the OR doors are universally open like that. They're not going to be locked. So push the door open with your back, and then you proceed to drying, gowning, and gloving. With the drying, make sure that you dry your hands really well, especially the fingers and the wedges. Gloves are going to be difficult to apply if there is moisture. And you also, moist environments are also a breeding ground for bacteria, which is what we don't want, right? As I believe Ms. Gonzales is going to take over from here. Ms. Gonzales, are you here?
Thank you, Ms. Ramirez. Okay, hi everybody. So I'm just basically going to talk over the video. Everything that Ms. Ramirez just went over in the previous slides is going to cover her demonstration here. Okay, so first approaching the sinks. to get ready and prepare going into the OR. She is checking for all PPE. Again, that includes the bouffant, your surgical mask, eye covers or eye protection, and shoe covers. A quick brief of your hands and arms to make sure there are no abrasions. She's going to grab the scrub brush, place it in one hand, and throw away the wrapper. Turn on with her knee the water, adjust the temperature, and check for time. Again, you want to gauge it to 1.5 minutes per arm. Sweep through, one sweep motion, forward motion for each arm under running water. One pump on the hand that does not, that you are not carrying the glove, and lather up all the way 2 inches above the elbow with soap. Switch hands of the brush and repeat with the opposite arm. So we want that soap to sit there and penetrate through the skin. Next step, you are going to use your nail pick and individually run it through under the nail, under the running water for every finger. And I'll also point out, don't be so quick to adjust the temperature, again, because she mentioned it's so cold in the OR and we want to just naturally put hot water to warm us up. 3 minutes into the scrub, that water can get pretty piping hot. So just a little bit above the medium of hot and cold is a good temperature. So after she went through each nail with the nail pick, she just turned, did a slight turn motion to turn, throw away the pick, again, not dropping her arm. Now she went through scrubbing with the bristles of the brush, scrubbed all of her nails in a back and forth motion, then starting with the thumb. And again, she went through all the planes, the 4 planes of the fingers, sides, front, back, and on the inside, going through every wedge, repeating for every finger. Again, it's very important to take your time during this. Again, we want that soap to sit. We don't want to have any gaps within our hands or fingers or nails. So we want a good lather of suds throughout our hand and arm. Please feel free to ask any questions throughout the video. So we are approaching the palm. This is where we begin our circular motion of the brush. On the palm, turn your hand to the back side, and then a circular motion at the wrist going down towards the elbow. And all you're doing is pivoting your arm back and forth. Again, be mindful not to straighten out your arm the whole time that you are going from wrist to elbow. Keep it at a not a 90 degree, but maybe a, what is it, a 35? I don't know my angles, sorry. So once she has completed the scrub all the way up to the elbow, she rinsed the brush, rinsed the hand only, and switched hands. Repeating the same method of applying more soap to the brush and going to the hand that is not yet scrubbed. We do not rinse the arm, only the hand. Again, we still want that soap there. Same steps as before, all fingers, nails, and in between. At any point that you were to drop your scrub brush during this process, you leave it there. You do not pick it up. It would be a good idea to ask someone to open a scrub brush for you. You grab the inside of it because that is considered sterile. Just a quick pinch of the inside of the brush and then start the process all over again. So anything that falls in the sink, do not pick up. Again, she is going in a circular motion, rotating her arm front to back, making her way all the way to 2 inches above the elbow, and a last rotation on the elbow itself. She will turn, drop the brush again from the height up here that you have your arms, never dropping your hand or arm. Once forward sweep through the water, beginning at the hand and finishing off at the elbow. And you can do multiple runs through. Again, be mindful as you're doing this that the opposite arm does stay up, fingers to the ceiling, so that the dirty water does not fall from your fingers. Instead, we want it dripping from your elbow. She turns off the water with her knee and just a few seconds stands there over the sink to let all the water drip, proceeds to walk to the OR, turns, and pushes the door with her back. Okay, so surgical hand rub. Again, what you saw was the surgical hand scrub, and that is to be done. It's a good habit to do it right when you enter into the OR and after lunch. When you do go into multiple procedures throughout the morning, once you've done your scrub, your first scrub of the day, from then on, you can use a surgical hand rub, which is the approved alcohol-based rub designated for use in surgery and can be used before going into the OR. You want to use the same motions of the surgical hand scrub, and a good method is a 3-pump method of the alcohol-based rub. You're going to use one method into the palm of your hand, and with this motion here, rub your fingernails and hand. A second pump all the way through your arm up to the 2 inches above the elbow. Repeat on the other hand, and then your third pump is going to be for just, again, hands, fingers, in between, and wrist. So your arms will be pretty wet at this point. So again, it's a vigorous rub. Get that friction going to penetrate the alcohol into your skin. From then you will, again, still walk into the OR the same way with arms up, and turn your back to open the door. Common errors of the surgical scrub: forgetting PPE, not checking for cuts and abrasions, contaminating while scrubbing, going back to a clean area, and splashing water. All these were mentioned before. Again, if you notice in the middle of the scrub that you do not have your goggles on and there's nobody around to help you put them on, we would tell our students, completely stop your scrub, dry your hands, put it on, or anything that you may have forgotten, and then start all over again from the beginning. For cuts and abrasions, if you do have a cut on your hand or arm, Band-Aids are considered sterile. So if you know beforehand, it is a good practice to open up a sterile Band-Aid to the surgical tech who is already gowned and gloved at the back table. They will take it for you and have it ready for you for when you come into the OR. After you dry your hands and arms, you can that Band-Aid will be handed to you and you can place on your cut. Again, we don't want to ever go from clean to dirty, meaning that if I have already scrubbed my hand and then just continued down to my elbow but missed a gap somewhere on my wrist, we don't want to go from the elbow back up here. So it's always just a one sweep motion and go from clean to dirty. Again, the water, it's a good thing to keep mind or be mindful of your distance to the sink to prevent all that splashing and that your scrubs don't get overly soaked. Hand drying. So the surgical technician who is already in the room and gowned and gloved will hand you an unfolded towel. It'll either be a blue towel or a white paper towel. They will hand it out and place it to you on your hand. So as you're coming into the OR, like with both hands facing up to the ceiling, you want to extend one hand out. They will place it there on your hand for you, and you will dry the opposite the wet hand. It's all blotting motion and of drying each finger individually, then pat drying all the way down. Same thing with the scrub. We're starting at the hand and going down to the elbow, pat drying all the way and still rotating your arm. Again, you don't want to go back and forth once from wet to dry and back up to wet. Once you are done with one hand, then you will do a sweep motion underneath the towel and repeat with the dry side of the towel, the opposite hand that is wet. Gowning a team members. So the surgical technician will position the gown. They will hold it up and unfold it so that it's completely open for you. You should be able to clearly see the arms visible so that you can slip into your arms. They will bring it up to your shoulders and keep your hands and arms in front of you. Again, you don't want to slip in your arm and just reach out like this or do some type of motion like this where you can potentially hit something or the surgical technician. Always keep it above waist. You never want to drop your hands. The surgical technician will glove you also. The circulator secures the neck behind you, and then once you are gloved, we'll show you in the next slide how to properly turn the tag with a circulator. So the surgical technician will orient the glove so that the palm of the glove faces you. A good rule of thumb is that the thumb of the glove is facing you, and that's how you know which hand to put in. Insert your hand into the glove and repeat the process. So we have a little video here of what the surgical technician will do for you as far as gloving. She will open the glove, place her fingers underneath to create that hole and opening for you, and you slip in. Again, it's almost like a scoop motion where you slip in your hand and come immediately back up. Repeat for the other side. So this is the tag. Once the gown is on and your gloves are donned, there is a tag that is right in front of your gown. You will grab the tag and disengage the tag and hand it to the circulator. So you will have one string. You will hold on to one string, hand the tag off to the circulator or a sterile technician. They will go around you to the back with good distance, of course, because the back is considered contaminated. So they will keep their distance from your back. Circle around you. You will do a slight turn, just a very slight minimal turn to grab a hold of the strings from the tag. And you will just pull it. As you see here, the ST rotates the shoulders to receive the tie with the left hand. You will then secure both ties, just like your shoelace, tying a shoelace, and maintain hands in your sterile area, which is a good indicator is at your belly button. Glove or gown contamination. If you have a contaminated glove, if you think you may have hit something that is not contaminated, again, this is where your surgical conscious comes in, and it's so important for you to say something. If you are in doubt, let somebody know. If you run into something, rubbed something, either equipment or person that is not sterile, again, you want to say something to them so that we can correct it. So for a contaminated glove, if you are already double gloved, then what you would do is let the circulator know, and she will put on non-sterile gloves and remove that top glove from you. And then you can repeat to put on a second pair of gloves if you wish. For your gown, what we would put or apply what is called a sleeve, a sterile sleeve. That will be opened by the circulator to the surgical technician, and you will place it in. Again, it's just a sweep motion through the sleeve, and it will protect and cover up what was contaminated. And it's pretty long. It does go from your wrist all the way up to mid-arm, around your bicep area. Again, no dropping of the hands. You never want to go below your belly button or waist level. This is considered contaminated. And showing of the cuff, anything white from the cuff of your sleeve that may show and slip past the sterile glove is considered contaminated. You then at this point want to let somebody know that you need to re-gown and glove. Removing sterile attire. At the end of the case, there is a proper way to break, scrub, and remove your gown and gloves. You will first break your tie, the one that you either tied like a shoelace when you did that turning motion. You're going to break that, then do a crisscross of the arms at the shoulders to pull and snap the tie that's in the back. You will pull away from you and then kind of do a wrapping motion of the gown as you pull it off. So you will pull the sleeves downwards and roll the gown inside out. Roll the gown so contaminated surface is inward. Dispose in a biohazard bag and remove the gloves. So as you're removing gloves, you want to do a hook motion of your gloved hand to your gloved at the wrist. And you're just going to do a scooping and take it off. Hold that dirty glove in your gloved hand, and then with your clean finger, slip in through the wrist and pull off. So it's glove to glove, skin to skin, and then you will throw away and dispose of. So standard precautions. All these are rules developed by the CDC. They are known as universal precautions. Every bodily fluid is considered a potential source of infection, as well as patients themselves. You know, we're cutting them open in a sense, and anything that they may have prior to coming in is a potential hazard to be splashed to you, which is why it's so important to always keep covered as far as your hair, your eyes, your face, and extra protections on your hands. Questions?